malfunction. I apologize now. There's a lot of noise in the background. There's a digger outside my office just finishing off our multi-story car park. So if you can't hear me at any point in time, Deb, just raise your hand and we'll see what we can do. Before we start, can I just introduce the team that are doing all the hard work behind the scenes? Simon Mendy, just wave and say hello, Simon. Fatima Ahmed, Fatima, are you on? Would you like to turn your camera on and say hello? Hi, Sarah Hussain.
Hi, everyone.
Hiya.
And Dev Amblegan. Hi. So everybody, thanks for joining me. It's the 31st of March. I know it's a difficult time of year. Hopefully all the payments that you need to have made at this point will have been made. And I hope now that we can spend the next hour giving you a bit of personal development and, as I say, helping everybody to feel comfortable about the cultural diversity issues that we're trying to improve. Today, we have a very special speaker joining us live from Texas in the USA, Tammy Jackson. When I first met Tammy was the Vice President of TransUnion Healthcare. Tammy will tell us a little bit more about her new role, how her old role has changed. And Tammy is still the National Chair of HFMA USA. So some of you will have heard Tammy speak at the National HFMA conference in December when we talked about how racial disparity affects health and healthcare in the USA. Tammy went on to talk about how we eliminate some of the unfair and preventable differences brought about by not just individual but institutional attitudes and practices. So now's the chance to hear again about those issues, but also the opportunity for us to ask some questions from the comfort of your own homes and your offices, and to delve into some of those issues a little bit more. So at that point, I'm going to hand over to Tammy to introduce herself and start her talk. Over to you, Tammy.
Thank you. Thank you so much, Don, and thank you to the rest of the team as well. Don, can you hear me okay with a thumbs up there? Okay. All right. Perfect. So a little bit about myself, and maybe that just might help provide you with some context as to what maybe informs my perspective or my initiative as I've approached my year as National Chair for HFMA US. And before I do so, I just want to thank you all for not only the invitation to be here and share with you my message, but the warm welcome I received not only in November and from this team here. So thank you to the team. So looking forward to spending this next hour with you. As Don mentioned, just as you know, as of late, back in November, I was Vice President with TransUnion Healthcare and had kind of broad responsibility for a number of different teams. And TransUnion is a national credit bureau. They focus in healthcare. So we were delivering data and analytics, not only around financial instability and insecurity and so forth, but also insurance eligibility, and then also social determinants of health. And so that was kind of our focus. In December, we were acquired by a company called nThrive. And so I am currently the Chief Growth Officer at nThrive, reporting into the CEO. We are a healthcare information technology company. And so we have all of that very rich data and then a whole bunch of technology assets. And so we help to support finance and revenue cycle over, thousands of providers here in the United States, payer space as well. In my capacity, I have broad responsibility for all of our client-facing functions, some sales, operations, and enablement functions, and then I also help to respond to the payer space as well. I have about 20-something years with TransUnion, so in that revenue cycle space. But in the middle of that, I had left TransUnion to really work on value-based care. And that is really the beginnings of my passion around equity in healthcare. And I think, as we'll get into here in a little bit, kind of what we were learning about ourselves as a country, and not so good all the time over the last 2020, 2021, really inspired my theme that we'll talk about today. And much like how HFMA UK, that the chair kind of adopts a theme. And so coming out of the beginnings of the pandemic, because we're still in the midst of it, coming out of the beginnings of it, I just saw a really good opportunity to use the platform to promote issues of diversity, equity, and inclusion, health equity, and while at the same time create a call of action for us to just be better than we were before. So with that, I'm going to share a slide deck with you. And hopefully you can see just a slide. I'm trusting that that is how it's coming over. Okay, I see Don nodding his head. So bolder, brighter, better. That is the theme that I have adopted for my year as national chair for 2021, 2022. And again, I think the preface of this was really around how could we pay homage to kind of the journey that we had all been through in the year 2020, while at the same time create a call to action. So let's start just by kind of reflecting on some other kind of pivotal moments, right? So HFMA, before we even dive into that, we are celebrating in the US our 75 years of being an association. And so we're about 85,000 members strong right now. And so it's an incredible amount of growth. But again, kind of the year that was leading up to my year as chair, it was not only the pandemic. I was supposed to actually have the year 2020, 2021, and we stalled our governance process and my year got pushed back. And so as we navigated the path through the pandemic, widespread social unrest that I'm sure each one of you had seen on the television, extreme political divisiveness that still carries over in today. So we saw that coming into our 2020 elections. You saw that in our Capitol riot on January 6th at the beginning of 2021. If we reflect on 2021, we started the year dealing with the Delta variant, and then that, supply chain issues, inflation, all of that, and leading into what we were dealing with at the end of the year, which was the Omicron variant, which happened to coincide with my visit to the UK, which made it incredibly interesting as I tried to navigate all of the different, the changing requirements that were going on at that time. But, I think as I reflect on that time, we were literally just, sitting and bearing witness to the life as we knew it change. And so I really think of this time, and I think we would all agree, this really serves as almost this pivot in time, right? In this period of time, what started as just 2020 is now 2020, 2021, and even rolling into 2022. But it's this pivot that qualifies everything else that has happened or will happen to us as either before or after. We will forever reflect on things as, well, that was before the pandemic or after the pandemic. And so what I think is really interesting is this universal shared experience. So, with us being in different countries, we have all experienced it. Every single person on the globe has experienced this pandemic, this period of time in some way, but it is nuanced by our personal struggles, and that makes it uniquely our own. And so I think that's just really fascinating. And so as I prepared for my year, I struggled with finding a message that seemed appropriate, right? Seemed up to the challenge and able to meet the moment. And so fully recognizing that our lives are really the compilation of these kinds of qualifiers, right? These events that that they're informed by, they're compilations of chapters that are informed by events, and they're colored by our reactions to those events and the end resulting changes. And so in order to kind of get ready, I looked to the past. And so I reflected on, the horrible toll of World War II that we're all familiar with. And this was a collective toll, and certainly uniquely experienced by those of you in the UK, and experienced uniquely by those of us in the United States. But the collective toll included tens of millions of lives that were lost, including over 6 million European Jews that were lost to genocide. And this was over a period of 6 years. However, that story also includes, that there were prior inequities in the domestic U.S. workplace that were smoothed out. And it really provided a more meaningful entrance for women into the workplace. And, we were able to increase industrial productivity by 96%, largely on the backs of those women, and the middle class expanded. It changed industries as it was, that horrible toll includes that story as well. When I reflect on, the tragic assassination of John Fitzgerald Kennedy, President John Fitzgerald Kennedy, and the state in which it left our country. And again, this is news that you all are familiar with as well. It's been widely debated since his tragic assassination whether or not his presidency actually would have changed the world, but it is generally accepted that his tragic assassination, and that story also includes that it essentially guaranteed the passage of the Civil Rights Act of 1964, which to this day is cited as one of the most significant legislative achievements in American history. In short, it changed our society. Okay, so it includes that as well. And then finally, we're all familiar with the horrible events of September 11th in 2001. And really, when trying to find and reflect on any good that may have come out of those horrible events, I was introduced to the story of Tiffany Petrella. And Tiffany was a recent college graduate. She was working in the coveted fashion industry job for fashion icon Kate Spade down in Lower Manhattan when the Twin Towers were attacked. And she remembers of this day only this distinct, disabling fear that the world was collapsing around her. And all she could do was run. And she spent the next 6 years trying to understand why. She lived in a Zen monastery. She became a yoga instructor. She took graduate courses in peace studies and conflict resolution. And today, she no longer works in the fashion industry. In fact, she is a director of student services at a Buddhist college in Oregon. And she says that the tragic events of that day changed her life and gave it more meaning. And I think there's many that would attest that the horrible events, that story also includes, this other narrative where it changed the lives of many people. And so you see, I wanted to a theme that would altogether acknowledge our shared journey, paid homage to it, celebrate what we had accomplished, while at the same time creating this call to action to be better in light of what we were learning about ourselves. I wanted a theme that would challenge our membership to reflect on answering the question, so now what? Where do we go from here? And so when we reflect on, those policies and those processes that have informed our healthcare industry prior to the year 2020, what will be the story, what will be the narrative that will be included because of the bold decisions that we made and the initiatives that we had deployed. When we're reflecting on the wicked business problems that we're trying to solve, here as an association, the way that we collaborate and learn and educate and network, what will be the story of, HFMA, and how were we made better as a result of 2020, 2021. And then, I reflect on what will the generations that follow say that we did to forge a brighter path forward for our society. And, that's at the crux of it all, really. How were we made better? Those social norms, that are never written, but well understood. What will generations that follow say that we did to forge a brighter path forward for these individuals? And so I just hinted at, a little bit of what I think my theme captures. And that's bolder, bolder, brighter, better. That's the theme that I ended up with. That's the crux of it all. But I just hinted at kind of what I believe our industry can do to apply this theme, and that is to promote health equity. And so I'm sure you're wondering, I don't know, and I love this forum and kind of the objective of it all is you all gather here periodically to discuss what can each and every individual one of us do. And in fact, there's a lot of stuff that we can really do. So if you're asking that question, I don't know how I can promote health equity from the chair within which I sit. I would challenge and say that, yes, you can. I think when I reflect on as a professional, what who has worked with social determinants of health, and value-based care reimbursement models, what resonates for me is that our before narrative, right? It represents these huge disparities in disease prevalence and mortality rates, access to care, and particularly relevant, for us over these last couple of years, access to COVID-19 testing and vaccinations and things like that. And so I'm begging the question, right? So where do we go from there? So here, this is data from the Kaiser Family Foundation. And so we see here that premature to excess death rates in the United States for 2020 was an estimated 500,000 excess deaths in the year 2020 compared to prior years. When you translate that to actual years of life that were lost, it's 3.6 million years of life that were lost. And when you see here in the United States, we actually compared horribly to peer countries of similar wealth. And so you'll see even there, we lost an average of 14 years for those individuals under the year of 75 years of age compared to 8 years of life that were lost for our peer countries. And you see the UK immediately below the United States. Here in the United States, that higher premature death rate was driven in part due to racial disparities. So American Indians and Alaska Native, Black, Native Hawaiian, and other Pacific Islanders and Hispanic people had a premature excess death rate in 2020 more than 3 times that of white and Asian people. Of the potential years of life that were lost, that 3.6 million years of life, 30% were among Blacks and 31% was among Hispanic people. And that is far disproportionate to the population that they occupy within the United States. All of this I fully recognize with my background. I fully recognize that it's due to the vulnerabilities that are driven by social determinants of health. But the fact of the matter is, it isn't new. And so health disparities has been long documented and researched for decades, right? So we've known this. This is long part of our before narrative. This is information that is on American Indians. And we have known since the 1950s that American Indians are dying from, their death rate dying from diabetes far exceeds that for white Americans, and their pace only continues to increase, far disproportionate, as you can see, to that of white Americans. This here is our data from the from 2006. And so we can see here, this is from the CDC, that we knew back in 2006, and this is just the earliest data that I could find, that we were dispensing opioids at far greater rates in rural communities. Those darker shaded areas here on the map, those are primarily rural states for us. We were dispensing it in far greater rates in those areas than we were in urban cities. And it took quite a bit of time after 2006, I can tell you, before the opioid crisis really gained national attention and national funding. It wasn't until it spilled into the cities. So we were okay with it as long as it was retained within the rural areas. We see here, again, from the CDC, this is 2015 data. They documented dramatic disparities in alcohol use, cigarette use, and serious psychological distress among bisexual, gay, and lesbian adults as compared to heterosexual adults. And then while I can go on digging into many of these marginalized groups, the one last point I will make is relative to disabled Americans. And so this is data drawn from 2009 to 2011. It is from Healthy People 2020. And it informs us that disabled Americans are more likely to be obese and to smoke. And as a result, they have a higher rate of diabetes and cardiovascular disease. But furthermore, they're more likely to be victims of crime, unemployed, less educated, have less access to transportation and the internet. And so, you know, it doesn't matter if you're acquainted, if you knew about all this stuff in the past, we now know it, right? And so, you know, much like the murder of George Floyd that we all witnessed back in May 25th of 2020, once we see that kind of stuff, my challenge to the HFMA membership is we just can't make believe that we don't know it exists. We can't pretend that we don't know that we have these kind of social issues. We can't pretend that we don't know that social determinants of health are manifesting themselves in such inequitable ways in these marginalized cohorts. And so I'm hopeful that we will not accept that and that we should begin to try to find ways where we can, with what each one of us can do. And so I reflect a lot on this particular quote from the Robert Wood Johnson Foundation. And that is in 2017, they had said, if we are serious about eliminating unfair, preventable differences in health outcomes, we must eliminate unfair social conditions that give rise to them. And it went on to say this will require meaningful changes in a number of areas, including both individual attitudes and practices, as well as institutional practices. And that is where you do come in. And so individual practices. So there are different ways to do this. There's designing a revenue cycle that can be executed equitably across all demographic groups, including and beyond race. It is designing an accessible digital front door, right, that makes healthcare more financially attainable and more readily accessible by anyone, regardless of socioeconomic or sociodemographic status. Designing a telehealth strategy that is inclusive, right? So making sure everybody can walk through your doors and can experience your financial protocols, your financial processes, your systems, whether they be digital or on-site, that everybody, regardless of whether they speak your language, whether they're a citizen, whether they are disabled, whether or not they are transgender, what have you, that they can experience that in the same way. And that you're doing what you can to meet them where they're at. And so you might not be the one that's building or buying the solutions if you are executing them, if you're like myself and you're selling into the industry. We all can serve as a critical filter. It's a first filter where we can call out inequities when we see them. And so no matter your role, there's much that we can do to make bold decisions and promote health equity. If we are well informed and we're well educated and we're well intentioned, our future looks brighter. And I believe that we can be better than we were before. And I would say that we must be better than we were before. I'm hopeful that the before narrative, that the disparities that we just talked about that resonate with me professionally actually leads to what resonates with me personally as well. Because I do feel as though promoting an equitable healthcare system is part and parcel to creating an equitable society, for caring for one another equitably. And that's part of it all. Healthcare is integral to our livelihoods here, but it's also integral to our communities and our lives. And so I will concede that while health and healthcare disparities manifest themselves strongly across socio-demographic lines, it doesn't simply mean it's a bias that's associated with geography or insurance status, race, disabilities. I get all that. In fact, it's not simple at all. It is health and healthcare disparities. They are manifestations, again, as I said previously, of vulnerabilities exposed by social determinants of health. And that is the wider set of forces and systems that influence 80% of a patient's wellness. And unfortunately, social determinants of health plague these marginalized groups that you see on the screen here in inequitable ways, and it leaves them more vulnerable. And again, we have to make sure that we're doing what we can to meet people where they're at. So while we as an industry may not have control over the many social circumstances that that may exist, I don't think that lets us off the hook. Okay, we have to own that we've been party to this system that has created these inequities. We have all, each one of us have participated in that. And we have to reflect on what we can do, what we have done, and when we have sat idle. And that is why I would like to see us all apply that bolder, brighter, better theme to promote issues of diversity and inclusion. My personal perspective as a Black woman who is also the mother of a Black son has forced me to confront and acknowledge where we are at with these issues as a country. And frankly, sometimes that personal perspective is somewhat at odds with my professional one. And so, you know, as a professional, I might say, I don't know what we can do about all this, but the personal side of me says, seriously, can we seriously sit here and say that there's nothing that we can do? We have certainly, we've done a lot of work, and it's forums exactly like this. It's creating the forums to have the conversations, and we've now named it, right? So we now have language for it. We have implicit biases, and we have microaggressions. And so you might not be, you may be fortunate enough not to have experienced greater obstacles to health based on criteria of race, sexual orientation, age, religion, physical disability, cognitive health, language, citizenship, et cetera, all of that criteria that I had just put on this slide. But I would venture to say that every single one of you knows what it feels like to be doubted and to be prejudged, and that is to be marginalized, right? So we automatically think about some of the characteristics I just listed, but those implicit biases and microaggressions go well beyond that. And there are some examples, powerful ones, I think, on the screen here. But, you know, we might think, so what does that look like? There's examples here for sure, but it's the questions or comments, or the comments that follow questions, or the looks that follow questions, and maybe sometimes the questions themselves about where you went to school, what kind of a degree do you have, why don't you celebrate Christmas? You know, what do you mean you don't go to you don't participate in this kind of event? Is English your first language? It also looks like when you walk into a room and someone is surprised that it's you that's been assigned such an important project. It also looks like, you know, a surprise when you get promoted and not somebody else that may have been more expected. For me, I reflect on my, you know, when I was in high school, a meeting with a guidance counselor. And when I shared with that person my top 2 choices for colleges of where I wanted to go, I was discouraged not to apply because I was reaching too high. I ended up at my first choice. It looks like a mentor in my, you know, my professional career who told me I should be happy with a particular role, that essentially that was my ceiling. I have far surpassed that role that person had said was big enough for me. In a clinical setting, right? So in a clinical setting, it looks like a physician who was visiting with my son and my son was young and had like this sudden weight loss, and it was somewhat unexplained, without asking me one question about our lifestyle, had told me I should stop feeding him fried chicken and fast foods. And at the time we were vegetarians. And at HFMA, it looks like an executive meeting that I was in, and we went outside to take a picture, and a CEO actually said it was windy and the women were complaining about the wind blowing their hair, and the CEO yelled out, "Put Tammy on the end, her hair doesn't move," and then proceeded to laugh. But it's these kinds of microaggressions and implicit biases that play in the back of our head and tell us that we're not good enough or we don't belong, right? And they manifest themselves, as I explained, in our schools, in our offices, in our clinical settings, and in fact, at HFMA. And so you might not be like me at the intersection of the marginalized cohorts of female and Black, But let's be clear, women and people of color aren't the only ones who are subject to microaggressions, implicit biases. Everyone knows what it feels like to be marginalized. And so I ask you to reflect on that, reflect on a time when you didn't feel included, and hold on to that and let that enable you to be empathetic. Because if this perpetuates, if it manifests itself with people with not applying to jobs that they're qualified for because they don't think they'll get it anyway, or not apply to them, it manifests themselves with people not seeking care because they're apprehensive about the experience that they'll have when they arrive in our offices. It's about, not higher education or participating in particular meetings or showing up at an HFMA meeting to make sure that for fear that they won't be included. So what's next? What does after look like for us? We've got to ask ourselves those hard questions as an association, within our organizations, within our offices. How do we identify talent for leadership positions? Are we intentional about mentoring programs, choosing people that might be the less than obvious choice? It's our natural inclination to choose people that we can relate to, that look like us. And I would challenge you to choose that person that you just see the skills in, and make sure, and you'll find the similarities there. We have to widen the lens to make room at the table for people who might not fit in. We have to figure out, how do we bring people in to create that diverse set of perspectives and thoughts and opinions at the table. And again, I'm not only talking about racial diversity, age, disability, LGBTQ, language, all of that. And so just as I encouraged my US colleagues, I would encourage you as well. I encourage you to be bold. We are writing the story right now that future generations will tell. And I'm confident that we are up to the task. I'm so encouraged, not only that we can forge a brighter path forward for our better tomorrow, but that we will. And so, and that I think that concludes my formal remarks, Dawn. So I'm right at the 30 minutes like I thought I would be. So hopefully that provides us with some opportunity for questions or anything else.
Thank you, Tammy. Fantastic. Let me just tell everybody that it's actually 8:30 in the morning in Texas at the moment. So that was fantastic, Tammy. Very early. We're in the afternoon over here. We really appreciate that. So, I mean, clearly marginalization anywhere is inexcusable, especially inexcusable in healthcare, and especially in our bit of healthcare. And you've given us a fantastic agenda to work on. In particular, the leaders of the future. You can do so much. Some of us are a bit longer in the tooth. We tend to think we're limited in what we can achieve, but the group that we've got here is diverse. We've got all ages. We've got leaders. We've got junior staff from a whole range of groups. The power that we have if we keep talking about these issues and keep moving forward, making incremental steps, is huge. I don't know if there are any questions in the box. If there aren't at the moment, I wonder if I can take chair's privilege and just ask one that I have, Tammy. Just something that intrigues me. Before 2016, I was really optimistic about the direction that the US was heading in, with the Affordable Care Act, and obviously with Obama being president. I just wanted your personal perspective on how US society might have changed since 2016 and what it might have meant for healthcare. You've got a change in political, we did have a change in political direction. We had the pandemic. There was a move towards a more equitable health system, but how have you seen things change over the last 5 or 6 years?
Yeah, that is an important question, and we could spend a lot of time on that. And as Don had mentioned earlier, I live in Texas, and so we're an incredibly conservative state, and so I experience a lot of the divisiveness that we've seen over the last now 6 years in a different way than some of our other states. I agree. I think that in 2016, with the passage of the Affordable Care Act and all of that, I do think we were creating those, we were beginning to meet people where they were at. What I also believe to be true is that that it didn't create, I think it with the presidency of Donald Trump, right? So if we're just going to call it out, right, when it shifted away from Obama to Trump, and we began to kind of see, I think, what was always there. So it's just, Trump gave our country permission to be exactly who we were, and it wasn't very pretty. And so I think, you know, whereas we were kind of in check before and you weren't allowed, you didn't have permission to just say what you wanted to say or act like you wanted to act. Donald Trump gave us that permission. And so we got to see a lot of who we were. And so I think what it's done is it has forced us to acknowledge that, right? And also allowed us the opportunity to start to dig in and try to correct those things. And I think we are getting back to, I think particularly the pandemic almost forced us to pivot back to, okay, we do have to focus on these inequities. It just exacerbated all of the problems. And again, it forces us to say, like I said before, it's decades worth of data. This is not all new stuff. And so I think it allows us to really change the narrative and say, okay, we really have to start paying attention to these inequities. And these inequities are in fact real. They're not fake. It's not fake news. It's documented, it's data, it's all there. So I do think now in the healthcare system, there's a lot of work going on right now around health equity and promoting health equity. There is and so much so that it is an undercurrent in almost anything that you do here in the United States related to healthcare. They are always now trying to make sure, it's not perfect, but there is an undercurrent of sensitivity around, are you collecting the right data so you at least know how your programs impact different communities? So for example, the CMS, right, that administers our government programs, even, you know, all of our value-based care programs, so our bundled payments and all of that. One of the administrators of CMS said, you know what, we didn't even have the data to understand who was actually benefiting from those programs. And so it forces people to go back and say, okay, now we have to at least collect the data so we can begin to understand that, wow, these programs are being administered in these communities that afford only a certain population to be able to take advantage of them. And so I do think there's definitely a high focus on it. Lots of different, we do a lot of work at my company with social determinants of health. So there's a definite desire to get the data that people need so that they understand how to meet people where they're at. The challenge that we have here in the United States is we don't compensate for that appropriately. And so what the providers are trying to really struggle with is, how do I do this important and good work and get paid for it? And at the end of the day, we're all trying to run a business, and these are business decisions. They have to be funded. And so that's really the push-pull. And I don't know how long it will take us to work through that, Dawn, but I hope in my lifetime we'll figure it out.
Oh, thanks, Tommy. That's really good. Simon and Dev, how are we doing for questions in the chat? Do you want to call out one or two of the most popular questions that are coming through?
Yes, Simon, you go first. I've got a couple for Menti as well. Then,
Don, my question is very popular. I'll ask my question. It's in the chat. You might not be able to see it, Tammy, but it's just trying to contrast the US and the UK healthcare system, given yours is a largely private funded healthcare system. Ours is publicly funded with a single pay. And it's free at the point of need, so it's not dependent on whether you have the ability to pay. I'm just wondering, what are we doing wrong if largely inequity is linked to deprivation in some cases, and it's free at the point of need? What are we doing wrong, and what is our role as a finance community to improve the health of the population as a whole, regardless of your level of income? And it was good to see, well, not good, but seeing some of the similarities in terms of opiate prescription in your rural areas and rural communities. We see the same thing in the UK as well. Some of our rural communities, largely coastal, have a significant amount of opiate prescription. I'm just trying to see whether we should see better outcomes, given ours is free at the point of need, but we see some real significant similarities in terms of outcomes.
Yeah, no, that's a great question, and definitely. So I'll give you my perspective. Right, it's not because I wish I had all the answers. I'd be incredibly busy if I did with fielding all kinds of inquiries. But I will say, when I went over to the UK in November, because you have a single payer system, I really did think that was the solution to all the world's problems, right? And so I was like, they've got this all figured out. And so when I sat through the presentations, I was surprised how similar our problems really were. So to your point, right? So I think what that tells us is it tells us that it's not a payer related problem, that it's not only a payer related problem. So I think in the UK, you all are dealing with a lot of what we're dealing with. It's just creating the access to care and making sure that people can experience it in the same way. So let me give you an example. And this came up, we did a podcast, and if you got Voices of Healthcare is an HFMA podcast. I'm sure that you can access it from wherever you get your podcasts. It was a few podcasts ago. They had a gentleman from the Center of Transgender Equality in Washington, DC, and he was, I might not get his title right, but he was like the head of that, executive director or something like that. And he was talking about how transgender people will forego care 25% of the time due to the experience that they have when they show up. So it has nothing to do with whether or not they can afford it. It is that when they walk into a waiting room here in the United States, it is difficult and particularly more increasingly difficult depending on where you live to get your documents to match your outward appearance, right? So if you want to change your name or change your gender on your birth certificate or your driver's license, there's prohibitions to that. So sometimes it is a state law that you cannot. Sometimes it's financially, you just can't afford it. And so only 11% of transgender people have documents, their healthcare card, their driver's license, their birth certificate that all match. And so when they walk into an office, sometimes, there's not a mechanism within the system that says, do your documents match? Do your documents match? Or there's not a field in there that says, what's your preferred name? So that when I show up and maybe my birth certificate says Thomas, and I show up and I like to be called by Tammy, when you call me out in a waiting room and you say, Thomas Jackson, and I stand up, you've essentially outed me in front of a whole bunch of people, and it's uncomfortable. And so that's how we can work to create access to care, to make sure that people just experience it the same way and that they don't hesitate to access it. And when we talk about like telehealth, I had cause to experience a telehealth visit not long ago. And so I really put on a different filter going through that process. And I will say it wasn't the most friendly process. And I'm not a technology genius, but I can find my way around a website and all of that. I had no idea what to expect. I didn't know when I logged in, I didn't know was somebody going to be, it was somewhat intimidating. And I think it would be very intimidating for somebody that maybe was struggling with a language barrier, that maybe was not as technically savvy, and therefore I might not even try. And so I think it's those things. It's like it's not always an affordability issue. That's certainly part of it, and that's absolutely part of it in the United States. But I think in the UK, it's trying to find where are those communities that don't know how to access the system, that don't understand how to navigate the landscape, that don't that from a cultural perspective, are we culturally sensitive so that we can engage with those communities in a way that will be accepting, and that where you can gain trust. And I think that's part of it as well. I was at a HFMA meeting in New York, and the Safety Net Hospital there, which is the indigent care hospital, they have a community of American Indians, and they went into the community. Those American Indians had never been vaccinated, had never had health care in their communities. And this is an indigent facility, so it would have been free. They've never come here. They had to go there, and they had to gain trust with those communities. So I think that's part of, what some of the barriers are. I hope that answers the question.
Thank you. I think
that was helpful, Tammy. Thank you. That's fantastic. Deb, have we got any other questions?
Yes, we do. So the first question that came in, Tammy, is, are there particular examples of work you have seen that has had significant impact on tackling the health inequity? Would you mind sharing that with us so that we can learn and probably practice that as well? Thank you.
Yeah, I'll share with you kind of a big example. So I get really excited about large scale interventions, right? So ProMedica healthcare system is a healthcare system here, and they have locations in Ohio and Michigan, and they have made a commitment to addressing social determinants of health, and they have acknowledged that means it goes outside of their clinical walls. So what they did is they've partnered with this company that have quantified risk across the communities that they serve. So they look at a community level and they say, what's the risk exposure of this community? And then they've also quantified at an individual level who's at elevated risk of these risk exposures. But what the data will tell you is not only, because it's not only important to know that somebody is food insecure, but it's equally important to know why. So it might not only be that, I'm a diabetic and I don't really understand what food to buy. So a literacy campaign might not do. So, that might not help me if my real problem is I can't afford the good food that I need. And so it's addressing the drivers. And so ProMedica they've established this Social Determinants of Health Institute. They're dealing with food insecurity that is driven by inaccessibility to the food and unaffordability of the food. So they put a nonprofit grocery store in the middle of what was a food desert. And that way people can get fresh groceries. Inside of that grocery store, they have nutrition counseling if that's what somebody needs, but they also fund what's called an impact fund. And that allows them to deliver fresh groceries to people who have an acute need of food supplies. They also have a financial opportunity center where they help to work with people to build financial resilience. And so it's incredible. They've had first of all, the Food Impact Fund. Every single cohort that uses the clinic has seen decreases and readmissions, ER utilization, and PMPM per member per month cost over a 12-month period. Every cohort that has seen that increase. On the Financial Opportunity Center, everyone that has used the clinic, on average, they've experienced a $210 increase in monthly income, 122 points for their credit scores, both of which are critically important for long-term financial resilience and success. Financial insecurity will manifest itself in a number of different ways. So lots of good examples.
That's helpful. Thank you, Tammy. We also have another question. Simon, do you want to go on the chat box first.
Yeah, Todd has asked a question. Todd, do you mind coming on camera and asking your question? Or do you want me to ask it on your behalf?
Hi, I have turned my camera on. I can't see myself, but I hope you can see me.
We know who you are, Todd, don't worry.
Okay. My question was really from the slide relating to equality and equity was where can we find those 3 additional fruit boxes that are needed to move from equality to equity? We seem to be doing the same things all the time and expecting change, but what can we really do to make that change?
Yeah, so I think that's a great question, and so I'll answer that a couple of different ways. So in the example I already provided around the transgender challenge, one thing that you can do, and is quite simple, that won't cost you anything, is do cultural sensitivity training, right? So that you can so that people know how to interface with individuals that might not feel comfortable. If you have the capability to put it in your system, you can add a couple of fields that will help that frontline staff kind of engage with those individuals so that they feel more comfortable coming in. And those couple of fields are, do your documents match? What is your preferred name that you like to be called? And if it's a sheet of paper, adding that so that somebody can actually call that person by their name. When I talk about an inclusive telehealth practice, right? So it is setting up time ahead of time to make sure staff and physicians are able to screen for technology accessibility requirements, making sure they're culturally sensitive. It is something as simple as reaching out to individuals that are scheduled for telehealth visits ahead of time so that you can ask them in a language and by a means that's preferable to them so that they can ask questions. Because if my preferred language and means is Spanish over the phone, and then I am trying to navigate this piece of equipment and there's somebody here trying to make sure I understand, the chances are that I will forget many of the questions that I wanted to ask my physician about my condition. And that is meeting somebody where they're at. That's giving somebody an equal opportunity to experience healthcare. It's like, I'm so inundated with this that I don't even have an equal opportunity. When we talk about digital front door strategies, it is presenting people with whether it's customizable options and, do they want to get literature in a particular language? Do they want, and this gets into a lot of the price stuff, which you don't have to deal with. But, for us, it's about price transparency, upfront estimates and things like that. But there's a lot of stuff I think that that we can do. And, even the example I mentioned with myself, with my physician that just said, stop feeding your kid fried chicken. I have fried chicken in the past, but it's not very good. So it's that kind of stuff, and it's creating these forums. And I'll be honest with you, it is not, it's up to, for those of us that may be in a marginalized cohort, it is also up to us to hold people accountable. It is important for us to say, hey, that's not right, and here's why, because assuming people are well-intentioned, they might not always be trying to marginalize, but they may be doing so. And so there's some level of accountability on us too. Todd, I don't know if that answered your question.
Yes, I think it does certainly help. I think a certain amount of self-awareness is necessary, and to see things from other people's perspectives too.
That's a great question, Todd. That's really helpful. And yeah, we have scheduled what has been called cultural intelligence questions, cultural intelligence training to to sort of make people aware of the sorts of things that they should consider when changing the way that we provide services in the way that Tammy describes. I think we've got time for one more question before we wrap up, because I do want to allow those commissioners that owe my trust money to pay me that money before the 31st of March. So do we have one more question, Simon and Deb?
Yes, I've got one on Menti, Don. So Tammy, given the political influence of Donald Trump on the healthcare access to the most privileged in the US, how do you see the health inequality issues in the US improving in the next 5, 10, 15 years? What needs to be done differently now? There's quite a bit of challenge.
Yeah, it is a bit of a challenge. I think that there's a lot. It's a good question, and I would say even difficult to answer right now. Quite honestly, I don't know if you all are dealing with kind of the staff shortages and all that you are. So the cost of our traveling nurses is unsustainable. And so there's a lot of that's going on that the healthcare system is trying to manage here in short order. Like I said before, I do think that there's an undercurrent of we're trying to collect the data now. And I think that is, even in the work I do, that is what's going to be most telling. And I think, they are trying to make some changes. There's, our government programs are beginning to expand, and that will allow people to bring more people into the fold. They are trying to improve some of the benefits for our Medicare, our 65 and older adults here, to include mental health benefits, improve the prescriptions and the prescription coverage and things like that. So I think they're trying to make the programs bigger, make them more accessible. I think we're collecting the right data. Well, we're trying. We know what data needs to be collected to make sure we can identify those areas of inequities. And I do think there's a level of accountability now. If you are getting government money, you have to be able to respond to inequities. So you can't close down, and this was happening. If you have 7 COVID-19 vaccination sites, you can't close the 3 that are in minority communities and not have to answer for that. And so I think there's, again, with that undercurrent of sensitivity, I think it's also bringing about accountability while we are trying to quickly pull in the data that we need that can really drive large-scale change.
That's great. Thanks, Tammy.
Thank you so much, Tammy. That's brilliant. So we're getting close to the end of our hour. They always go so quickly, don't they? And you've left us all with some fantastic takeaway points. I mean, we all know, Tammy, and you've emphasised it here brilliantly, that we're here to provide a universally equitable health service. And in order to do that properly, we need a diverse workforce. We need to recognise what diversity really means in the way that all of our staff are treated. I took away some important messages like we just need to be honest about what's happening, where the inequities are, how our staff are being treated, and where we need to make improvements. It was interesting to hear your point about inequity is not just a payer method or an affordability issue. And a lot of the inequity derives from the experience that people have in accessing healthcare, and the way that we treat a diverse population creates a barrier to access. So we need to work on that. I'm going to look at this podcast, Voices of Healthcare. Great example of the power of risk stratification. As I said earlier to Todd about we're going to try and cram into an hour. We're trying to keep these sessions to an hour, but there's a great little session on cultural intelligence that we want to run, which will help all of us in the journey that we're on. Just left really to thank you, Tammy, for getting up so early to talk to us this morning. We really appreciate it.
No, thank you. This has been really nice. I really appreciate the time. I encourage and am impressed by the interest in the forum that you've created here, Don. It's super important, and so kudos. This is good stuff, and this is how we change the narrative and make our after story different than our before story.
Thank you, Tammy. And finally, thanks Simon, Dev, Sarah and Fatima for your help in organising today. And then thank all of you for joining us today. And commissioners, pay that money.